Good morning. Welcome you all for the second day's first session. So, without wasting any time, we would like to invite Dr. Prathap Jethwani, sir, who is going to speak on handling the nightmare, nocturnal hypoglycemia. Prathap Jethwani, sir, is current National Treasurer, RSSDI 2026-28, past National Joint Secretary of RSSDI. Over to you, sir.
Thank you. Let me first thank Dr. Srinivas and the team I led for inviting me to be part of this scientific event at Bengaluru. And he has given me this task of some new topic, that is handling the nightmare nocturnal hypoglycemia. Slides are not moving. Done. So we all know that hypoglycemia is one of the main barriers, both in type 1 and insulin-treated type 2 diabetic patients to achieve glycemic control. And almost more than 50% of these episodes, they occur during night, and they are unnoticed by both patient and their caregivers. And it imposes not only a substantial physiological, but also psychological and socio-economic burden on people with diabetes. It is the same definition as hypoglycemia, that is glucose levels below 70 milligram per deciliter, but it occurs during night, that is between 12 midnight to 6 a.m. Up to 50% of severe hypoglycemic events, they occur at night, and most of them, they are missed by SMBG unless and until the patient measures blood sugar at 3 a.m., which is very much not possible for all the people. And most of the time, they are having long duration during the night, and they are one of the important risk factors for the development of hypoglycemia unawareness. So if we see the epidemiology and prevalence, this is data from Europe. This is predictive analysis, this is European cohort. If you see nocturnal hypoglycemia, 13.8 episodes per year in type 1 diabetes and 3.4 episodes per year in type 2 diabetes, and they are having positive association with duration of diabetes, number of insulin injections, and fasting glucose variability, but they were inversely related to HbA1c, fasting glucose, and body mass index. If we see the South Asian data, this is the International Operations Hypoglycemia Assessment Tool Study, which was conducted across the globe in 32 countries, and this is analysis of the Southeast Asian cohort of this study, and they have tried to identify, they have done both the analysis, retrospective as well as prospective. Retrospective over a period of last 4 months, and prospective over a period of next 2 weeks, 4 weeks and 2 weeks. And if you see here the nocturnal hypoglycemia, any level of nocturnal hypoglycemia in around 12.5% in retrospective and 11.2% in prospective, and severe hypoglycemia or less than 54 in 3.9% in retrospective analysis and 2.9% in prospective analysis, and it was highest in people who were using premixed insulin injection, and also it was related with diabetes duration. And they also confirmed that it increased healthcare utilization and reduced productivity, and we need to focus on this hypoglycemia, particularly nocturnal hypoglycemia also. So what happens if hypoglycemia occurs during sleep? There is a reduced arousal, because threshold for awakening is significantly lower, particularly during REM sleep compared to stage 4 sleep. The glucose utilization is very high during REM sleep, thereby increasing the chances of hypoglycemia. The autonomic tone or autonomic drive is reduced during different sleep cycles, it differs. So there is risk of decreased counter-regulatory hormone response to low blood sugar, particularly during this dead zone, that is between 2 a.m. and 4 a.m., where physiological nadir occurs. At that point of time, there is an increased risk of hypoglycemia, and there is a decreased chances of counter-regulatory hormone response as well as awakening, and this is one of the reasons why it results in dead in bed syndrome that I will touch upon in subsequent slides. So what is the impact of nocturnal hypoglycemia? It has got impact not only on glucose control and glucose variability, sleep and quality of life, but it has got some serious concerns. It has got impact on cardiovascular events, particularly arrhythmias, mortality, cognitive impairment and dementia, it is costly affair, and ultimately it is one of the main risk factors for the development of hypoglycemia unawareness. So let's start with what is its impact on glucose control and glycemic variability. This is first data, CGM data of 185 study participants, type 1 diabetes, and CGM they have considered hypoglycemia. It was, if it was low blood sugar was persisted for at least 15 minutes, then it was considered an hypoglycemic event. And if you see these two graphs, this is general hypoglycemic events per week, and the second graph is level 2 hypoglycemic events per week, and there is overall night, day and night. Night is in blue. And if you see the people who were having very good glucose control, more than 85% time in range, contrary to our belief, the risk of nocturnal hypoglycemia was lowest in this category of patients. We might think that tight glucose control increases the risk of hypoglycemia, but here the people who were having time in range less than 70, they were having at more risk of developing nocturnal hypoglycemia, be it general hypoglycemic events or level 2 nocturnal hypoglycemic events. And they also confirmed that they are significantly longer, 60 minutes as compared to 35 minutes during daytime, and they were not associated with rebound hyperglycemia on the second day. On the second day, they also measured glucose levels, and there was a decrease in time above range, mean glucose levels and morning glucose levels, and an increase in time below range and coefficient of variation. So there is no rebound hyperglycemia. It is contrary to the belief of Somogyi phenomenon, where nocturnal hypoglycemia results in rebound hyperglycemia second day. But most of the evidence is against Somogyi phenomenon, and it is now considered more a fiction than a fact. This is one of the very good analysis where 755 patients, 10,000 nights, they have tried to find out how many patients they develop hyperglycemia in response to nocturnal hypoglycemia during night, and they identified that 32.8% of patients, they had one or more episode of post-hypoglycemic nocturnal hypoglycemia. But if you see the number of nights, it is only 3.9%. So when your night blood glucose is low or you develop nocturnal hypoglycemia, the chances that your morning blood glucose will be higher is less than 3.9% or 4%. Most of the time the morning glucose will also be low. It has definitely got impact on cardiovascular disease. It affects hemodynamics, myocardial blood flow, oxidative stress increases, inflammation increases, prothrombosis increases, and there is definite impact on cardiac depolarization that results in an increased risk of cardiac arrhythmias. And this is evidence. This is daytime hypoglycemia, this is nocturnal hypoglycemia, and if you see that bradycardia, atrial ectopics, ventricular premature beats, all were significantly associated with nocturnal hypoglycemia as compared to daytime hypoglycemia. And that's why this phenomenon occurs particularly in children and adolescents with type 1 diabetes, that during 2 to 4 a.m., because of the nocturnal hypoglycemia, lot of changes takes place in cardiac electrophysiology that results in an increased risk of cardiac arrhythmias because of sympathoadrenal activation, QT prolongation, inflammation, bradycardia, and multiple other things, and that results in the sudden death in bed, and that is also being termed as dead in bed syndrome. What about the impact on quality of life? There is a fear of hypo, which results the patient will not intensify or optimize therapy, and that's why they will not reach the targets. There is a sleep disruption that will result in daytime fatigue and impact on the quality of life, and there is a lot of psychological distress both for patients and caregivers. It also is a very important risk factor for development of hypoglycemia associated autonomic failure because it goes unnoticed, and if keeps on recurring, then it will result in blunting of sympathoadrenal response to low blood glucose, and that will result in the development of hypoglycemia unawareness. When to suspect, this is the ISPAT Clinical Practice Guidelines 2022. Nocturnal hypoglycemia should be suspected if pre-breakfast glucose is low, or the individual experiences confusion, nightmares, or seizures during the night, or if there is an impaired thinking, altered mood or headache, upon awakening, then this should be considered as a feature of nocturnal hypoglycemia, and either the patient should be subjected to CGM or midnight glucose at 3 a.m. should be measured. So it is recommended to monitor overnight glucose levels if the patient is having additional risk factor, young age, lower HbA1c levels, afternoon exercise or evening exercise, particularly in type 1 children and adolescents, and daytime hypoglycemia. They give a hint that this patient is also at risk of nocturnal hypoglycemia, and these are the precipitating factors which we all know, that is excess insulin, less food, exercise, alcohol ingestion and sleep. They can precipitate the risk of nocturnal hypoglycemia. So late day exercise is one of the important reasons, particularly in type 1 children. There is delays glucose uptake, and that results in nocturnal hypoglycemia. You need to reduce basal insulin or give bedtime steak. Alcohol intake can inhibit hepatic gluconeogenesis, so it is to be consumed with carbohydrates. NPH insulin, I think we need to use more of a basal insulin analogs rather than premix or NPH containing components, so that we can avoid the unpredictable peak which occurs at around 4 to 8 hours and contributes to nocturnal hypoglycemia. So how can we diagnose? I think SMBG, it misses the nadar between 2 and 4 a.m. And if you keep patient to measure blood sugar at 3 a.m. every day or twice a week or even once a week, that will be definitely not feasible for everyone to do, and that results in patient burnout. So CGM is the way forward, and with the CGM you can diagnose 73% of nocturnal hypoglycemias in type 1 and 43% in type 2, which were missed by SMBG, and therefore CGM is the tool to diagnose nocturnal hypoglycemia. But whenever you are using CGM, you have to be aware about this artifact, that is compression loss. Whenever there is a localized pressure on the sensor, then it restricts the interstitial fluid flow, that results in a sudden rapid drop in sensor glucose, and this can be identified sharp vertical drops and immediate rapid recoveries which don't match the physiological slope of true hypoglycemia. True hypoglycemia, glucose goes down and gradually recovers. In this it will be a sharp drop and then sharp up. So this is generally because of the compression of the sensor. It may result in false diagnosis of nocturnal hypoglycemia. You may revise your treatment, and that may unnecessarily harm the patient, and therefore during night, if the sugar goes very low, you always confirm with SMBG if the CGM reading doesn't match symptoms or clinical context. Patient education is must as far as management is concerned. You have to counsel them about dose adjustment for eating and insulin. Spouse should be trained about this. Proactive adjustments in response to activity and meal timing should be done. And fear management is must, because otherwise the patients will not follow your treatment plan properly. Basal insulin, we all know we have evolved from the NPH to glargine U100. Now we are in the era of second generation ultra long acting basal insulin analogs, that is glargine U300 and degludec. And I think there is substantial evidence to support the use of this second generation basal insulin analogs, particularly in people who are at risk of developing nocturnal hypoglycemia. This is edition 1, 2, 3, where glargine U100 was compared with glargine U100. There is 25% reduction in hypoglycemia as compared to in type 2 diabetes, and weight gain is slightly lower. Same is evidence is available with insulin degludec also. Switch studies, type 1, type 2, there is a reduction in nocturnal hypoglycemia with both in type 1 and type 2 diabetes. And if you compare both of this, then the BRIGHT study, which is a open label randomized study, which says that during titration phase, U300 fares better than insulin degludec as far as nocturnal hypoglycemia is concerned. Otherwise, both are same. So choice of analog should be individualized based on patient cost, titration needs, and flexibility. So you can use basal insulin analogs to avoid nocturnal hypoglycemia. This is one data which is published recently in 2021. This is Chinese study where they have tried to put type 2 diabetic patients who were not controlled on oral drugs to either U300 or NPH, and then they have done CGM. And this CGM, they have confirmed that both were having same mean blood glucose, or time in range was not much better with U300 as compared to NPH, but the nocturnal hypoglycemia, if you see, it is much less with glargine 300 as compared to NPH. And that's why they confirmed that if you want to avoid hypoglycemia, you have to use better molecules like ultra long-acting basal insulin analog, glargine U300. Technology can help you. There are predictive low glucose suspend in insulin pumps. There are hybrid closed loop delivery where modulates basal delivery every 5 minutes based on CGM trends, and this can result in dramatic improvement in time in range without increasing the time below range. So you can avoid nocturnal hypoglycemia with the help of advancements in insulin pump technology also. And these are trials which support this, ADAPT trial, FLAIR trial, and the real world data. All this, they support that you can use these automated insulin delivery devices to improve time in range, and at the same time you will be able to reduce time below range, particularly during night. A word about elderly, because it is a risk factor, and also it is because of cognitive decline. It can result in frailty, falls and fractures. De-intensification of therapy is must, and CGM is generally underutilized in elderly people, which is to be used much more frequently, particularly if the elderly person is on insulin therapy. Do use CGM to identify whether they are developing asymptomatic hypoglycemia during daytime or night. Following exercise is very much important in children. This is very good data that 1 hour of afternoon exercise, 48% of people, they develop less than 60 glucose during night, and the maximum low occurred between midnight and 2 a.m. And this you can avoid by reducing the basal insulin during exercise and for few hours after exercise, so that the nocturnal hypoglycemia you can avoid. These are the newer technologies where they are using machine learning algorithms in the form of random forest and superior vector machines to identify, to predict the nocturnal hypoglycemia, particularly in type 1 diabetic individuals. And they are there, and soon we will be having CGM systems with this predictive algorithms which can give patient a hint that they are at risk of developing nocturnal hypoglycemia during night, and they can do proactive adjustments in the insulin and avoid nocturnal hypoglycemia. So these are the future directions: once weekly basal insulin, glucose responsive insulin, and these predictive models. They can help in preventing nocturnal hypoglycemia in people having both type 1 and type 2 diabetes. So to conclude, I will say nocturnal hypoglycemia is no longer an inevitable nightmare, because with modern insulin analogs, with modern technologies like CGM, like automated insulin delivery, the predictive algorithms, we can achieve good glucose control without increasing the risk of nocturnal hypoglycemia. Thank you again, Dr. Srinivas and the team ILET, for inviting me to be part of this symposium.
Hello, thank you, Dr. Jethwani. Any questions we can take from the audience?
So I think, Prathap, one thing I learned from your talk, which is very nice, about that artificial hypoglycemia.
Yes.
It's a very, very subtle clinical point.
Yes.
That is something which should be highlighted more, because that is something people will take as a very good, useful clinical tool.
Yes. And second thing is, even with second generation, there is still risk of hypo. Still there is a risk of hypo that everyone has to keep in mind. Thank you. Yes?
I had a patient where at around 3:30 in the morning, there was one episode of hypoglycemia. It went down to around 40, 45, not diabetic, for instance. So I think because the CGM machine was installed, and it was monitored, and it stayed for almost 1 hour during that, like between 40 to 70, I can say 65 or so. So is it cautious? We need to be cautious on this, or it's since one episode.
Was it on the first day of installation?
No. It was, I think, on 6th day, and the patient had not taken any drinks or anything like that. And
No, was it confirmed with SMBG?
No, it was only through.
So
CGM.
first thing, CGMs, there are more chances of lows during night. That is very common. So they overdiagnose hypoglycemia, particularly during night period. And there is many which are because of this compression and other things. So whenever during night, if the patient is not having any complaints and CGM is showing hypo, check them to confirm with SMBG. Many a times it will not be hypo.
Okay.
because still, and CGM, they are going to have, in near future, they are going to have newer terminology of sensor detected hypoglycemia rather than the hypoglycemia
No,
which is detected by SMBG.
But the patient complained that he had severe
Stomach
appetite.
ache.
No, I mean like
Yeah,
he
so
wanted to have some.
So I think sometimes hypoglycemia is unexplained. If we look at it, in an ideal world, everything has to be explained. But sometimes some patient, because of something, less exercise, more activity, less eating, may get a hypoglycemia.
So physiological can also
can happen.
yes.
If it's matching with his symptoms, then it's a hypoglycemia. And, ideally, you would have checked, but if it's matching with
No,
his
my
symptoms,
concern is it worrisome wherein you need
If,
to.
if it persists, if it is occurring daily on a regular basis, then it is a worrisome. If it is an isolated episode
it's not
which occurs once during 15 days period, you need not to worry about it. This, as Mithun told, it may be because of excess activity or something change in their schedule, because physiological hypoglycemia is also very common.
One thing he said that he had severe stress in the past 2 days, but generally stress causes increase of
So
the.
in my mother, stress causes hypoglycemia.
Hypoglycemia.
I can tell that 100%.
Okay.
So we worry more when she's stressed.
Okay. Okay.
Or else same time you can check next few days,
Yes.
then you can confirm it.
Fine.
Thank you.
Thank you.
Let's appreciate our speaker with a big enthusiastic round of applause. Thank you, dear speaker, respected chairperson, for your valuable insights. May I now request our esteemed chairperson and speaker to kindly proceed to the selfie stand for a photograph and with a memento.